Good day, everyone.
This meeting is being recorded.
Thank you for joining us at Project Hope for this session on Building Back Better in Maternal, Newborn, and Child Health, with today's focus being on reducing neonatal mortality in northern Ghana, a decade of experience from a neonatal center at Tamale Teaching Hospital. My name is Dr. Tom Kenyon. I'll serve as your moderator today. I'm the Chief Health Officer at Project Hope, which is a global health, development, and humanitarian organization for over the past 60 years. My background's in pediatric medicine and global public health. Let me begin by introducing today's phenomenal panelists. This is really a terrific group. First, it's my pleasure to welcome Dr. Leah Greenspan, who is the Senior Newborn Advisor at USAID since 2020, where her focus is advancing the care for small and sick newborns around the world. Leah is a board-certified neonatologist practicing in the DC area for almost 20 years. She's worked extensively with numerous NGOs and ministries of health to build the capacity of medical professionals and to strengthen health systems around the continuum of maternal newborn care in Africa and Asia. Our second speaker is Dr. Al-Hassan Abdul Mumin, the Associate Professor of Pediatrics and Consultant Pediatrician in the School of Medicine at the University for Development Studies and the Tamale Teaching Hospital. He also heads the Department of Pediatrics and Child Health in both institutions, where he's been working for 11 years now, expanding specialist child health services in the Tamale Teaching Hospital and Northern Ghana. This includes setting up neonatal units and primary and secondary health facilities in the 5 regions of Northern Ghana in partnership with the Ghana Health Service, who will also be joining us today. As a medical educator, he's contributed to the training of more than 1,000 medical students and junior doctors to augment the medical doctor workforce in Northern Ghana in particular, and Ghana as a whole. Joining Dr. Al-Hassan are 3 other members of the maternal newborn team in Ghana. First is Dr. Isabella Sago Moses, who's at the national level. She's the Deputy Director of Family Health Division in the Ghana Health Service. Isabella is a medical doctor with specialization in child health and is responsible for coordination of reproductive and child health programs at the national level. This includes advocacy, planning, budgeting, monitoring and evaluation, policy development, guidelines, and training. Among her many achievements are introduction of Ghana's scorecard on reproductive, maternal, newborn, child, and adolescent health, along with introduction of IMCI in Ghana. She led coordination for development of Ghana's first and second newborn strategy and action plan and chairs the National Newborn Steering Committee. She's also served on various WHO committees for the development of standards for quality of care for newborn and child health, and as a co-researcher on a variety of studies. Our fourth presenter, but our second from Ghana itself, located in Ghana, is Dr. Mankala Adam, who's an obstetrician gynecologist with the Tamale Teaching Hospital and a senior lecturer with the University for Development Studies School of Medicine, Tamale. He is passionate about training the next generation of healthcare professionals using the problem-based learning and community-based education and service methodologies, and mentoring healthcare workers in the district facilities in Northern Ghana to improve maternal and perinatal outcomes. In this regard, he has maintained his teaching position with the University for Development Studies for more than 10 years, and is a key member of the Tamale Teaching Hospital maternal and newborn health outreach teams. And finally, we have Ms. Victoria Aguaya, a neonatal nurse specialist, also at Tamale Teaching Hospital. She's one of the 5 pioneer staff of the Tamale Teaching Hospital Neonatal Intensive Care Unit, or NICU. She's a member of the Ghana College of Nurses and Midwives, a neonatal nurse specialist, and the nurse in charge of the NICU. She's passionate about male partner participation and family-centered care for babies, both in the hospital and at home, in order to improve survival rates of the extremely preterm baby. She's the founder of a kangaroo support group for couples to educate, motivate, encourage, and support others who have preterm babies. And she's working on the role of community participation in newborn care in Northern Ghana. So with those introductions, Leah, I'm turning it over to you to make some opening remarks on behalf of USAID and present your presentation on global newborn trends and USAID's priority approaches. Thank you.
Good morning, good afternoon, and good evening. I want to send a thank you to the Project Hope team for inviting me to speak on behalf of all newborns, and to all friends and colleagues. Thank you all for joining both virtually and in person to share our passion for improving lives of mothers and newborns in Ghana and across the world. Again, I am honored to be here, and please know that my remarks are in service to the US government, not being made by the US government. To begin, big journeys begin with small steps. I will review this journey over the next 13 minutes and 20 seconds that will include background and updates that build the case to improve care around the time of birth, to the why we must build on keeping well babies well and provide quality advanced care for those that are small and sick, the driving force behind USAID's evolution in newborn programming. This journey will include discussions around global data, impact of lives saved, making the case of small and sick newborn care, why now? Global targets, global documents, and USAID's dual track approach and newborn health priorities. Let me briefly review the most recent causes of neonatal mortality as listed on the Healthy Newborn Network website for 2019. I'm sure you've all seen this, what I call multicolored donut, that shows that 36% of newborn deaths are related to prematurity and associated complications, the darker blue. Following clockwise, you see teal that shows that 24% of deaths are related to interpartum events. And following around, I combine the orange and the next blue to show you that 15% of newborn deaths across the world are due to sepsis and other infectious conditions, including pneumonia. We know high impact packages of care, integrated and aligned across the continuum of care, reduces newborn deaths. But let me speak to this slide specifically. If you look in the center, you can see that care during labor and childbirth reduces newborn deaths by 36%, as represented by the blue bar. While improving inpatient care of small and sick newborns, if you scroll across to the right, actually reduces newborn mortality with a 44% reduction. These findings are supported by evidence from high-income countries that have achieved a neonatal mortality rate of less than 12 only after expanding their focus to include and improve inpatient small and sick newborn care. The sad truth is, though, 30 million newborns require inpatient small and sick newborn care each year, but 80% actually do not receive it. Let's look at targets now. Targeting the small and sick newborn. Why now? Let's look at global trends. Since 2014, the global community has seen great progress with the decline of neonatal mortality from 31 per 1,000 live births to 18 where we stand today. But if I do the math correctly, we only have 8 years till the SDG targets for 2030, with the goal of reducing neonatal deaths to less than 12 per 1,000, and keeping in mind the ENAP target that also includes stillbirth rates of less than 12 per 1,000 by 2025. Remember, no country has had success in moving the needle without focusing on improving both obstetric and small and sick newborn care. To help guide us to improve care for the 30 million babies that require inpatient care, ENAP has developed a new target, the first of its kind that speaks specifically to small and sick newborns, but we'll discuss that in a few more minutes. Dr. Isabella, Dr. Al-Hassan, and Dr. Adam will speak more specifically to Ghana, but I did want to share and bring these targets up. Here on this slide, I find this slide very interesting because this is the projected mortality rates in 2030, given historic average annual rates of reduction since 2010. As you can see on the graph, the 3 bars in green on the bottom show only 3 USA-focused countries are currently on track to reach the SDG by 30, with Indonesia having already achieved that target Bangladesh and Nepal are on track, with Malawi very close. These projections are conducted by the United Nations Interagency Group for Child Mortality Estimation. I said we come back to the fourth ENAC target. It is essential to include quality of care for small and sick newborns to reach our SDGs. Thus, in 2020, ENAC proposed this fourth target specific for small and sick newborns, which states 80% of countries have an implementation plan for small and sick newborns, and 80% of districts have at least one level 2 inpatient unit to care for small and sick newborns with respiratory support, including the provision of CPAP. As ENAP speaks to level 2 care, I wanted to quickly remind you and bring attention to the WHO levels of care, where the global community and USAID focuses, so we're all on the same page. This graphic is from Survive and Thrive, Transforming Care for Every Small and Sick Newborn, and clearly defines 3 levels of care linked to their interventions. The second level, as you see, level 2 special newborn care, builds on the foundation of level 1, assuming that essential newborn care in level 1 is done with quality. And at the level 2, we bring in the 8 interventions as described on this graphic. In conjunction with the launch of ENAP at the 67th World Health Assembly in 2014, the global community has witnessed great progress, as I had mentioned earlier. But I want to review the timeline and the global recommendations that support and guide small and sick newborn care. 2014, 2 years after 2014, we have seen the standards for improving quality of maternal newborn care in health facilities was released. And it really put quality of care front and center, that looks not only at the provision of care, but also the experience of care. 3 years later, the launch of Survive and Thrive, Transforming Care for Small and Sick Newborns, actually built the case and mapped out pathways towards 2030. This document is a must-read in entirety, not just a skim for those engaged in newborn health, as it clearly highlights that if appropriate action is taken globally, small and sick newborns can and will survive and thrive as future productive members of society. This document was quickly followed by the quality standards for small and sick newborn care in 2020, which standardized and mainstream inpatient care, building on essential newborn care and ensuring consistency within the WHO quality of care framework. And this year was a busy year for the WHO. They actually published 2 documents, and this one, the Human Resource Strategies to Improve Newborn Care in Health Facilities and Low and Middle Income Countries, is fondly referred to by USAID as the HRH Roadmap. This looks at the question of human resources in health facilities comprehensively and highlights that an essential element to provide quality of care is healthcare workers with specialized knowledge and skills for newborns. This document also provides a framework and strategy for countries to transform their policies on human resources for health and provide their health workers with the knowledge and technical and behavioral skills necessary for high quality care by 2030 to ensure that all newborns survive and thrive. Though 2020 was busy, during the middle of the pandemic, the Nurturing Care for Every Newborn document was released, highlighting the need for these principles of infant and family-centered developmental care be at the core of all newborn services, no matter what level of care. What's new for the WHO? Well, in March of 22, a few months back, WHO released new recommendations for a positive postnatal experience for mothers. The most significant change presented within the recommendations is that with further evidence, chlorhexidine does not have the impact on neonatal outcomes as originally believed, and its indication is limited to use only in settings where harmful traditional substances are applied to the umbilical cord. Currently, the WHO is preparing to release new guidelines for preterm births and low birth weights, kangaroo mother care, caffeine use, caffeine as the drug of choice for apnea for prematurity, also updated guidance on use of antenatal corticosteroids, and we're eagerly awaiting a policy briefer to provide further guidance around chlorhexidine. As I come to the end of my time, I want to briefly discuss USAID's programming and priorities. Through this upside-down triangle, we put numbers of newborns cared for at the center of our programming, and it has evolved into a dual track approach. At the top of this upside-down triangle, you see track 1, which focuses on essential newborn care at the community and level 1 facilities. By providing quality of care that will impact the lives of 110 million newborns. Here, our intention is to keep well babies well. Track 2 builds on this foundation to provide level 2 care for small and sick newborn, impacting another additional 20 million babies, those that are small and sick. Lastly, I want to share with you USAID's MCHN approach to newborn health from an overarching perspective. We have harmonized our vision, goal, and objectives with the maternal health team, and their slide actually looks quite the same. Though busy, I want to bring you straight down to the 4th layer of the graphic, the navy blue, our strategic approaches. We have bundled interventions for 2 groups of newborns, which align with our dual track approach. Track 1, what every newborn should receive, including prevention of stillbirths, and track 2, building on this foundation for advanced care for what the small and sick newborn should receive specifically. If you just look down at the lower layer, you can see that we also need to consider newborn health through the critical lens of emerging trends that includes fragile settings and the impact of climate change on mothers and newborns. As I hand the floor or the screen over to the next speaker, Dr. Isabella Segamoses, I want to emphasize to you again that newborn care involves keeping well babies well. Do no harm. Pay attention to your unintended consequences and provide quality of care for those that are small and sick with a family-centered approach, always keeping the mother and the family at the center. Thank you again for your time and passion. We'll take questions at the end during the panel discussion, and I will now turn it over to Dr. Isabella Segamoses.
Thank you and good afternoon, good morning. I'm Isabella Segamoses and I'm happy to be presenting from the Ghana Health Service national perspective on what we've been doing to improve newborn health in Ghana. My slides will be uploading shortly.
Hi, Dr. Isabella. Do you mind trying to share the slides on your end?
All right, I'll do that. I guess this has to go off first. What's on the screen now? Is my screen visible?
Yes, it
Please
is.
checking if my screen. All right. Okay. So as I said, I'm presenting on Ghana's efforts to reduce preventable neonatal deaths. I will pick our story from 2008, when the Demographic and Health Survey showed that neonatal deaths were a major bottleneck to the reduction of under 5 mortality. At that time, initial steps were taken to improve the policies we had in place, including our policy for under 5s. Efforts were also made to improve the curricula of training institutions and also build some capacity for service providers who were already in practice. Mainly, we introduced the Helping Babies Breathe package, and we tried to roll it out. However, that did not yield much. And then in 2012, we held a National Newborn Stakeholders Conference. The stakeholders made a strong call for Ghana to have a standalone newborn strategy instead of merging it with under 5s. And this call was aimed at giving more focus to the newborn. So we introduced a separate national newborn health strategy, and a lot of other initiatives were taken to ensure that we stayed focused. And so here I have listed just a few examples of steps that show Ghana's commitments to reducing neonatal mortality. So for the first time in 2012, we had neonatal mortality included as one of our sector-wide indicators. This is a set of about 20, a little over 20 indicators that the ministry pays attention to regularly. And then we have prioritized neonatal health in our national quality care strategy, and is also listed among our priority services for our universal health coverage roadmap. Neonatal mortality reduction and other related indicators form part of our key performance indicators for health managers at various levels, like regional health directors and in charges of hospitals. We had very few separate newborn corners or areas when it all started, but currently we are counting close to 200 separate newborn care units across the country. And this is from an assessment that we've just completed. And we're happy to say that neonatal health is also included in plans and budgets at various levels of the healthcare system. So this is our first, the cover page of our first newborn strategy and action plan. It spanned the period 2014 to 2018. And we had a fairly ambitious goal of reducing neonatal mortality from 32 per 1,000 live births at the time in 2011 to 21. This first strategy was heavily focused on improving essential newborn care across the country. So by the end of that period, we had just begun to see a decline in our neonatal mortality rate from the 29, which we had in 2014, to 25, which is our latest figure. We are yet currently in process with the Demographic and Health Survey. This 2017 figure is the Ghana Maternal Health Survey figure that gave us 25. And so based on that, and after a review of what had been done, we came up with our next strategy, which we are currently operationalizing 2019 to 2023. And the different thing about the goals here is that we now have a goal for reducing institutional stillbirth rates, which we didn't have in the first one. So a few highlights. In this current strategy, our updated interventions include, whilst we are still working at essential newborn care and taking it to scale to all facilities that deliver babies, there is now a new focus on facility-based care for the at-risk, small and sick newborns. We are also looking at follow-up care, promoting the Survive and Thrive approach, and additionally, looking at providing psychosocial support for mothers and families who have adverse outcomes to pregnancy, and also working at promoting early childhood development. Now, a look at the key strategies that we are working at to achieve these goals. We are improving policies, standards, and documents that guide practice. We have done a lot about our health information management system. Initially, we had very, very few indicators. Now we've included a lot more, particularly looking at quality of care. Health financing is another key strategy. The procurement and distribution of essential medicines, devices, and commodities, and improving capacity of facility-level health workers. We also work towards building capacity of community health workers to promote newborn care. And in all our efforts, we aim at promoting and institutionalizing quality improvement, including supportive supervision and mentoring, strengthening advocacy, communication, and social mobilization, and improving our monitoring and evaluation, as well as strengthening partnerships with between the public and private sector. And private sector, I'm looking at private healthcare providers, as well as corporate agencies who support our efforts by financing some of our needs. I want to dwell a bit on this aspect, which has to do with managing our strategic plan. We have in place a committee we call the Subcommittee on Newborn Care, which coordinates and mobilizes resources and provides strategic direction. Representation is from the ministry, Ghana Health Service, academia, our partners, and some private providers. We meet quarterly to review progress and to plan. And 2 of our meetings out of the 4 for the year are joined by our regional focal persons. We have focal persons for newborn care in each of our 16 regions, and they join us twice in the year to present on progress with plans that have been outlined. And it's used also as a forum to discuss pertinent issues and updates and provide updates. Every year since 2012, we have continued with the National Newborn Stakeholders Conference, and it's a very good forum to help us share best practices, provide updates, and at the end of the conference, each region, as well as the national level, takes the area of focus for the particular year and puts in place plans to implement until the next conference. We just ended the 10th Newborn Stakeholders Conference last Thursday. These are examples of some of our documents. We produce the standards for newborn health services covering all newborns across board, but we've just finished adapting the WHO standard for small and sick newborns, which was launched during our last conference. These are other examples of our documents. Now, some key lessons learned. We've learned how important data is and for advocacy and to make sure that newborn health stays high on the agenda and also for tracking progress. We've also learned that it's important as government to coordinate because we have several partners and interest groups in newborn health with some resources. We want to make sure that we maximize our resources and as much as possible, we don't duplicate our efforts. Having a strategy has served us very well in providing direction and facilitating resource mobilization. And it brought us together to plan, and we continue to plan together, which also engenders commitment for implementation. Because once stakeholders are committed on some goals and they are part of it, everybody feels, everybody owns it and works towards achieving the goals. So these are just a few examples, and it's also important to create fora for sharing best practices. And some of the outcomes of our newborn conference has been facilities sending delegates to other facilities where they've seen some best practice to go and study and come and replicate. And that has helped to spread interventions across the country. We still have some major gaps existing. There are facilities that were not purpose-built, so did not have newborn centers, and these are in the majority. And so infrastructure space in particular is a challenge. Human resource capacity, generally for midwives and doctors, but particularly for providing specialized care for the small and sick newborns. We have very few pediatricians. There are whole regions that don't have pediatricians, and there are some who have just one or two. Talk about neonatologists, they are very, very few indeed, and then specialized nurses. Equipment gaps still exist. We are working towards data, but there are data inconsistencies which we are also trying to improve so that we can effectively use our data in planning. We've introduced quite a number of the key interventions, but not at scale. And we believe that unless we're able to do that, we may not see the dip in neonatal mortality that we expect to see. So in conclusion, I'll say that newborn health remains a priority for Ghana. We've achieved some progress, but there's a lot more that needs to be done. However, we believe that with the right investment, the existing gaps can be addressed to make newborns in Ghana survive and thrive. Thank you very much for your attention.
Thank you, Isabella, for that terrific overview and from the national perspective and to show what a national commitment to newborn health looks like. I don't think we have a lot of examples like you've just shown out there. A lot of it's, where do I start on this complex issue? And you've presented a very clear and convincing roadmap on how to address this complex issue. We're going to hear more now from Dr. Al-Hassan himself from the Tamale Teaching Hospital and his team. Over to you, Al-Hassan. Can you hear me? I think you're on mute. There you go.
Hello. Yes, I can hear you. Can you hear me?
I hear you fine. Thank you. And welcome.
Thank you so much. So, as introduced, my name is Al-Hassan Abdul Mumin, and then I work with the University for Development Studies and the Tamale Teaching Hospital, both in Tamale in northern Ghana. I will do this presentation on behalf of my other two colleagues, and they will be available for the panel discussions when the discussion is open. I'm just waiting a bit for the slides to come up. Yes, that's it.
Yeah.
Okay, I think we are good to go. Thank you so much. First, I will thank Project Hope for giving us the opportunity to share this our experience on newborn care in northern Ghana for the last 10 or so years. My presentation is made easier with the context that Dr. Isabella Sego-Moses has set from the national priorities. So this will be the outline. I will start with the background and then the work that we have been doing. And I will end with what we have done so far, and then our plans for going forward, and then some conclusions. Okay. So can I go ahead? Okay. Sorry, we are still trying to, sort out the. Is there a problem? No. It's okay then. Okay. So if you can hear me, then I'm continuing from for the presentation. With regard to the background, the Tamale Teaching Hospital was established as a regional hospital in 1974. So this served the then northern regions of Ghana, as seen in the map here. So northern region where Tamale is located, and then we have the 4 other regions. Two of them were original part of the northern region. So the Savannah and Northeast region were original part of the northern region. But the catchment area of the hospital now includes about 8 million population from the Ghana Statistical Service Population and Housing Census of 2020. And we also serve some part of the Bono East region and then the Oti regions currently. The hospital was upgraded into a teaching hospital in 2008, and it has a tripartite mandate, which includes providing advanced care education for healthcare professionals, and then conducting research and outreach programs. As the only teaching, tertiary hospital in the catchment area, it serves about 8 million population, as I mentioned earlier on. And the catchment area shown in the map here traditionally had a relatively high under 5 and infant mortality. And when compared to the other parts of the country, it's generally worse off. Regarding the neonatal intensive care unit, it was set up in 2009. This was part of the restructuring of the teaching hospital to start training junior doctors as in-house officers. So the time that it was set up had only 1 medical officer and then 3 nurses. And it was working out of a small cubicle in the maternity unit of the hospital. Right from the outset, the vision of the hospital, the unit was carved from the teaching hospital's vision, which is becoming a center of excellence in providing high quality tertiary care, education, that is medical education, and conducting research. So the slide here shows, the transformation that we have, the transition that we have gone through since the hospital was set up and since the newborn care unit was set up in 2009. Initially, so the incubator shown here was just actually a non-functional incubator, which was used mainly as a crib. And that was the only one that the unit had when it was set up in 2009. Then immediately the unit was set up, and word went out that there was a neonatal unit in the teaching hospital. There were quite a lot of referrals. Stating even expansion of the small cubicle in 2011 because admissions continued to go up. This and our work with corporate organizations in in Ghana led to a new structure, which was the first independent structure that we had for newborn care in the teaching hospital and even around northern Ghana. This was transitioned to the current place that we now work, which is within the maternity, the obstetrics area of the hospital. So the slide here compares the infrastructure, the equipment status since the start of the unit in 2009. So you see that when the unit started, there were virtually no equipment to work with. So we had only the non-functional incubator and then a single phototherapy machine, which was improvised using a local carpenter, and one pulse oximeter to check oxygen saturation. This has really, changed over the last 10 years, as even now we have 4 mechanical ventilators which are functioning, and then we have a transcutaneous delivery meter which we use for screening for jaundice before discharge from the hospital, and a host of other equipment. So the key change here has been our movement to the obstetrics and gynecology unit, department, which was built in 2018 by the government of Ghana. This area is now very close to the obstetrics department. I'm sure the teams here that have visited Tamale would have seen it, and also close to the obstetrics theater, making close working with the obstetrics teams a reality. And then the other issue has to do with the central oxygen that is provided within the unit, which we never had. And that has helped us to move away from the daily struggle for oxygen concentrators and oxygen cylinders to meet the needs of the unit. Of course, because of the awareness creators and more sick neonates being referred, we still have issues with crowding in the unit, despite the bigger space and more functional unit that we have now, and space for mothers whose babies are on admission. With regard to staffing, there has been also a significant change in the number of staff and the categories of staff that staff the neonatal unit since 2009. So from 4 to 94 in the total number of staff that work in the unit now, but also in the mix. As now, as Dr. Sebo Moses mentioned, there are very few neonatologists in the whole of Ghana, but our unit is now staffed by 1 neonatologist. The pediatric departments in general has about 8 specialists now, which is also a huge change from the time that I went to Tamale in 2010, 2011, when there was no pediatrician. And then 2 of them are dedicated, including the neonatologist working in the neonatal intensive care unit. The other key change here has been through the training from the Ghana College of Nurses and Midwives, which is a Government of Ghana program, and the support from Sick Kids Canada. We have neonatal nurses who have been trained, and 4 of them have completed their training as part of the hospital drive to get more staff for the hospital, and they have returned and they are now working in the neonatal unit. Of course, we also have a number of midwives, which is also a huge change, because originally there were no midwives working in the neonatal unit at all for some time. For clinical care, which is one of the key mandates of the Tamale Teaching Hospital, the slide here shows the trends and the changes in admissions since we started running the units in 2010. So 2010 was the first year that we had some reports. I must mention that for the earlier years, actually, there were no, independent data for the newborn as it was, added to the pediatric data for reporting from the hospital. So from 2010, we have the, admissions numbers for the newborn. And we can see that within the 10 or 11 years that we have been working, there has been about 230% increase in the number of admissions. This makes our unit a high burden, a high output neonatal intensive care unit by all standards. So there are three time periods that we can look at in this slide. The first period when the unit started, and then as I said, in 2012, 2011, because of the overcrowding, there was a slight expansion to the unit. And then in 2013, this also coincided with the implementation of the first National Newborn Health Plan, Strategy and Action Plan. That included helping to set up neonatal unit in the district facilities within the catchment area of the hospital. So from 2013 to 2017, this was the time that we started helping to set up some of the units in the district hospital. So before that, the neonatal unit in the teaching hospital was the only one that provided, care for sick neonates in the entire region that has about 8 million population. So there was a slight, although an increase, but slight reduction in the steep increase in admissions up to 2018. And then in 2018, when we moved to the new unit, also with more resources, and then more change in also the profile of the admissions, which included surgical cases as well. We see that they also has been another steep increase from 2019. COVID-19 affected and disrupted newborn care in Ghana as well, and then in northern Ghana. And as we showed from our study that we published in the Frontiers in Pediatrics, there was a total decline somehow in the admissions in 2020. And then from 2021, again, we can see an increase in the admissions of neonates into the unit. For the causes of admission, this is very similar to what we see in most neonatal units across Ghana and across the globe. But the key things I group in three time points again: the beginning, the middle, and then from 2020 and 2021. We would realize from the slide that the first blue color show the preterm and small babies admissions. In the first few years, majority of more of the admissions were due to asphyxia and sepsis. So we see that there were more bigger babies. And then the small baby and sick new preterm baby admissions started increasing up to the end of 2021. As we see now, we predominantly admit more preterm and small neonates compared to the other conditions. With regard to asphyxia, there was initially a drop in the admissions due to asphyxia, and as we'll see in the subsequent slide also, mortality due to asphyxia. We attributed this to the very intensive trainings that coincided with the launch of the National Newborn Health Strategy and Action Plan, which actually also coincided with the end of the MDGs era, where we had a flurry of activities leading to more capacity building of staff, both in the teaching hospital and in the districts. Unfortunately, this has not been completely sustained, and then in the latter years also we can observe an increase in the number in the admissions due to birth asphyxia. The other key change here that I would want to mention is the change in the admissions due to jaundice. We always thought that there were more neonates with jaundice who probably slipped through and are not admitted to hospital, maybe one due to lack of access and two due to lack of awareness. So with the newborn awareness campaigns, partly also driven by the Pediatric Society of Ghana, and also our quest to screen newborns who are high risk before discharge, we have noticed that there is a an increase in the number of babies who are admitted for jaundice. And this is a good thing because they are detected early and then admitted before they are discharged home. Therefore, I mean, we would reduce disability that may be due to severe jaundice. For mortality, we had an initial, I mean, more profound drop in mortality from 2010 to 2017. Again, this coincides with, I mean, the capacity building and then the provision of more equipment that we observe across Ghana and then also in the neonatal unit at Tamale Teaching Hospital between the 2012-2017 period. Overall, the drop has been more modest because at some point after 2018, there was also, I mean, apart from, there was also a reduction in capacity building opportunities, training opportunities, and also a high attrition of staff, which means that new staff moves in and out of the units, I mean, at various points. And training is required regularly to be able to maintain the gains that we've made over the period. They are, apart from that, in the last 2 years, so just before the advent of COVID, we started also, I mean, with the in-service trainings for, I mean, the care of the small and sick newborns and care for newborn resuscitation for asphyxia. This we thought would, I mean, help drive down again the mortality, but COVID has been, I mean, a huge disruptor during the period because there were fewer trainings that were instituted during the period, especially at the peak of the first and second waves. We have started that again in 2021, and we plan to build more capacity both within the hospital for the new staff that's recruited in both the maternity and then the pediatrics department, and also for the district hospitals. For the causes of mortality, as shown earlier by Leah, this also is very similar to what we would observe globally. And from our own publication, that was the study that was published in PLAS One in 2021, and also the publication on COVID and newborn health in 2021. This mainly due to preterm asphyxia, and then birth defects and sepsis. What we observed was, aside the decline in admission due to infection during the peak of the COVID, the mortality also due to infections slightly dropped in 2021, but we are seeing another increase from 2021 as well. There is a decline also, although slight, from mortality due to preterm birth. And we attribute that to, I mean, the availability of more skills from our the neonatal, both the neonatal nurses and then the neonatologists that we have been able to recruit into the unit, and then the limited scale of training that we have been conducting since, 2020. We have been working a lot in various fronts with the Ghana Health Service in Northern Ghana, which includes about 5 regions currently. And we work with them in terms of helping to build capacity of staff, helping to set up neonatal units, which also coincided started around 2012, 2013. We also do mentoring and supportive supervisory visits to the district hospitals to support the staff who take care of newborns and as well as maternal health. Then the other thing that we do is the community follow-up. Our nurses have been very instrumental in supporting with the routine visitation, and that we have identified a lot of advocates. So this picture here at the lower part shows a preterm baby that was born at 27 weeks and now 6 years old. Him and his father form part of our advocacy teams that when we are doing newborn health advocacy in both radio stations, and also using them as a support group for new mothers who have preterm babies on admissions. We also conduct a number of community-based studies to follow up our high-risk neonates, including moderate severe asphyxiated neonates, preterm breasts, and severe jaundice babies, to make sure to, document how they are faring after they have been discharged from the hospital. The specialist neonatal nurse play a key role in the work that we do. A number of them actually were part of the first cohort of staff who started working in the neonatal unit when it was set up in 2009. And in fact, the in charge of the unit now, who is also part of the panelists, was one of the 3 staff who were posted to the unit in 2009. And she has gone through to be trained as a neonatal nurse specialist. And she's now one of the key drivers of our work with the nursing care in the hospital. So since they returned in 2019, they have been supporting to improve infection prevention and control practices by restructuring the unit so that we have the baby neonates admitted because of infection, admitted to separate areas. They have also been key in building capacity of the general nurses. As we saw in my previous slides, we still have predominantly general nurses working in the unit, and it will take a long time for us to have more pediatric and neonatal nurses. So their capacity building is key. And they have been working very well also on resource mobilization, both to support patients and parents who are not able to afford and their babies are on admission, and also to support more equipping of the unit to provide better care. Education is another key aspect, both on radio and at various units within the continuum of care. So the other thing here that I want to mention about their role is the creation of the family-centered care and then the parent-to-parent support group for preterm neonates. It is especially very difficult for mothers, first-time mothers who have babies who are preterm. And the former parents of preterm babies are brought into the unit and also form part of the team that visits the homes of new mothers, such that they are able to give and boost their morale and let them know that the babies can survive and thrive if they concentrate on providing the care that is given them, taught them in the hospital. They have also done a first by involving fathers in doing kangaroo care in Tamale. So for Tamale, which is a very male-dominated area, this was really a very difficult feat to achieve. But with persistence, we now have, as at the end of 2021, about 21% of the fathers who accept and do kangaroo care very well. And actually in the community, they serve as voices to educate families during festivals that the fathers can actually take part in this family-centered care, and that improves the survival of their babies. There is also, we have limited space for full kangaroo mother care in general. So we just have 7 beds for kangaroo care. And at any point in time, we may have up to 20 babies who require that, this essential care. Therefore, they also work on intermittent kangaroo care for those who do not have the space initially. The obstetricians are very crucial to the success of our newborn care programs, and we have been working very closely with them. They have been part of even the outreach program that we ran to districts, so that we provide both maternal and newborn care capacity building along the continuum of care. In Tamale Teaching Hospital originally, they have been more obstetricians, and then the obstetric services have been more robust for a long time compared to pediatric services. They run high-risk pregnancy clinics, and also all complicated pregnancies are referred to the teaching hospital as the only tertiary facility within the catchment area. This makes it even more important that we work closely with them, because more and more of the complicated cases refer lead to deliveries of babies that need intensive care. And the close collaboration would mean that we actually are able to see this pregnant woman before the babies are delivered, and therefore they are referred very quickly into the neonatal unit. And as part of our combined district visits to the district facilities, we provide capacity building and make sure that, we work as a team so that we, to improve perinatal care outcomes in the catchment area. The maternal mortality, just like the neonatal mortality, was initially very high in the Tamale and then also in Northern Ghana, but with their efforts and then the work that we do together, there has been a decline over, the last decade. So most of the supportive supervisory visits and mentoring that we did to the peripheral facilities also were more regular up to the end of 2017. Recently, there have been a number of challenges. That means that we are not installed the process and we are not able to do regular visits. This is mainly due to constraints with resources. So there are key achievements over the period. One among them is the provision of more access for newborn care, as we saw in the admission trends. The other one has been our contribution to reduction in mortality in general in Northern Ghana. And Northern Ghana now has a relatively, better newborn mortality, neonatal mortality rates compared to 10 years ago. And we have been active also in conducting research to generate local knowledge and evidence so that that can contribute to better care for our newborn babies. We still have a number of challenges as the profile of the neonates that we take care of continue changing. One of them is space for especially mothers whose babies are on admission. The other one is the high workload that makes general nurses don't want to work in the unit for a long time. So this brings another challenge, because that means that we have a very high attrition rate, and therefore we have to be training new staff who are posted to the unit every now and then, making it very difficult for an improved continuity of care. And of course, the capacity building, the opportunities are fewer for in-service training and also training the lower level health facilities compared to the previous years. We have a medium to long-term plan on what we want to do moving ahead. This is because of the changes in the profile of the cases. So we see that we now have more small and sick neonates. We have a lot also of asphyxiated and severe jaundice babies who survive. This means that we need to move on from what we used to do. So one of the things that we plan to do is to have a comprehensive neonatal center, which would house both a kangaroo center, a post-discharge follow-up, which will be multidisciplinary, including screening, including play therapy, physiotherapy, and then our research center, which we now house in one of my offices in the hospital, then training for the hospital for all the staff who are sent from different areas in the catchment area. Then we have started at limited scale on screening programs, and I'm happy that the newborn screening for sickle cell disease is now on the agenda in Ghana as a whole, because we started the screening in last year with the support of the Sickle Cell Foundation Ghana. And I have a project that will sustain this screening program. We also screen for jaundice using the transcutaneous bilirubin meter, but then we would require a more robust screening program that would include retinopathy of prematurity and also screening the preterm babies less than 35 weeks using the cranial ultrasound. The outreach and supportive supervision visits remain a key issue on our agenda, because our experience have shown that when we keep touch and build the capacity at the lower levels, it improves the outcomes in even the teaching hospital. It also reduces the burden of the number of cases who are referred back to us from the district facility. So this is something that we think we have to keep on the agenda and do it more regularly. So for conclusions, we have seen a significant change in newborn care services over the last 10 years. The burden of disease and the profile has also changed over the period. The greater decline in mortality coincided with the end of the MDGs era. And this was the time that actually there was serious and frantic efforts to provide more capacity building and resources for newborn care. We think this needs to be sustained as we are more and more small and sick neonates, and those high-risk neonates are surviving. So there will be the need for to have a supportive supervision and to be able to sustain this change. As the high-risk neonates are surviving, continuity care programs are very key in making sure that they just don't survive, but they thrive and transform. And this is where our community visitation and the linkages with the lower level facilities is very important. I thank you all for listening, and again I thank Project Hope for giving me the opportunity to share the work that we have been doing in Tamale. Thank you.
Thank you, Dr. Al-Hassan, for that excellent overview of what you've done in Northern Ghana. I wonder if we could give your colleagues a chance if they have anything to add, Victoria or Dr. Adam, because I look at your team and it's the perfect team. You have Isabella at the national level with the public health perspective and the national perspective, doing the many important things you have to do at the national level in terms of driving this. But then you have the obstetrician, the pediatrician, and very importantly, the neonatal nurse who are there on the ground making this happen day in, day out. I was wondering if Victoria or Dr. Adam had anything to add or to this discussion. Thank you. I don't mean to put you on the spot.
Victoria, you are muted.
Oh, okay.
Okay, now we can hear you.
Okay.
Hello, can you hear me?
Yes.
Yes, we hear you very well, loud and clear.
Okay.
Okay. Hello?
Yes.
Yes. I think.
Yes, we hear you.
Pardon?
We
Yeah.
hear you.
Yeah, can you hear me?
Yes, we hear you fine.
Yes, yes. This Adam Munkaila. Thank you very much, Project for Hope, for the opportunity given us in Ghana. As Prof rightly mentioned, we work in partnership with the pediatric unit. 10 years ago, the neonatal intensive care unit was far from the obstetric unit. And even that, the problems, we had with them was if you have a baby that we needed to transport, there was a problem. But now they are in our building. And so we work in partnership with them. And one key thing that Prof has actually done when he came is to train our midwives in helping neonate brief. And so all the midwives who attend deliveries in the theater or in the labor ward, they have had this knowledge. And so we don't have problems with neonates, like we had before. Secondly, he also, stressed on the delay cord clamping, which was mentioned in one of the presentations. We used not to actually do it, but when he came, he actually, taught us, and then told us the importance of delay cord clamping. The other thing that we've done, which we didn't do earlier, was that we didn't have, gadgets to monitor the neonates, the pregnant women when they came in labor. Now we have some few CTGs, guided tachograph, to monitor the women when they're in labor, and we are achieving results. So, and when we have, preterm delivery, we usually inform the NICU team to come around, and then we do the delivery. And then if they have to resuscitate, they resuscitate, and we take the baby to the NICU unit for them to continue the care. So we are working closely with them and we are achieving results. Thank you very much.
Thank you. Victoria?
Yeah, thank you for the opportunity given me. Prof has said a lot concerning how neonatal intensive care units has gone far from 2009 up to date. We realized that beginning it was not easy, but we have come a long way to achieve what we want to achieve because of dedication and then resilience. We have come this far because we have decided to involve the patients into the care from onset when they are admitted in the neonatal intensive care unit. Looking back at northern Ghana, most of the times it is difficult for you to deal with the male partners incorporating with the care. They have a phenomenon that caring for children is basically meant for females, but their role is to just provide drugs or money. But we have decided to educate them and bring them to the understanding that we have gone past the stage where a female is solely to take care of the male, the neonates. So we decided to bring the traditional leaders into the care of the preterm babies. For instance, we have one of our neonatal advocates, the kangaroo father advocate, who is an elder, a chief in a sub-district in Tolmo district, who has been a very instrumental for our child care. That man has been able to educate a lot concerning neonatal care in northern Ghana. He's someone who advocates a lot about preterm babies. He himself had a preterm baby in our unit. So we have him involved in taking care of his child, helping him feeding the baby from the onset. So when he was able to incorporate all those things whilst he was on admission in the kangaroo care, he decided to carry the idea back into his community. So now we don't more get bad cases coming from that particular district. He is the one championing almost all the cases that have been sent into that particular district. Normally, he goes around with the health personnel to educate most of the colleagues, his male partners, who prove difficult in caring for their babies, that it is not only meant for female. He being a staff chief, he has decided to come to the level in which he will be able to care. We have been able to cooperate, even not only the males, but the politicians into the kangaroo father care group. We decided to form the kangaroo father care group because if we have those who are influential into the community in the care of our neonates, it goes a long way in reduction of neonatal mortality. For instance, the premature babies, normally when we started the neonatal intensive care unit way back from 2009, though we're not getting the preterm babies, just because we weren't having the equipment and the expertise to care for them. But now we have been able to survive babies who were born, especially 25 weeks gestation, who are doing well, they are alive and they are kicking, just because the fathers have been able to accept and also take part into the care of their babies right from the hospital and in the community. Doing this, you need to involve all the stakeholders in the community. So we have been able to identify those who are the influential people, especially the grandmothers, the old ladies, and then the mother-in-laws. If not that, when you educate them in the health institution and they finally get into the community, the mother-in-laws and then the father-in-laws and even the elders in the community, if they are not able to understand what you have educate them in the health facility, all what we have done will become zero. But now we are making a link into the various community to incorporate our care, but not only in the health institution, but in the district itself. Thank you.
Thank you for sharing that. And the role of men in this is very important. And actually, I haven't heard of many examples like you've just described in Ghana of male involvement. I've seen men involved in kangaroo mother care. They can do KMC as well as the mother herself can, and that's obviously very important for the bonding aspect as well, which is very important for the long-term outcome. We have one question from our audience, and let me see if I can bring that up. And it focused. The question was around nursing, Victoria, and I was going to ask this too because this has been a challenge everywhere. It's the rotation of nurses, and you know this better than anyone. You get a nurse in the NICU, they become experienced, but then for whatever reason want to move on, or as a hospital, you have to rotate staff for staffing considerations. How have you managed that? How have you managed to keep a strong NICU presence with respect to nursing? Because that you want the experienced nurse there who can guide the others who are less experienced. And as you know better than anyone, neonatal nursing isn't for everyone. It's hard work. It's very demanding. It's 24/7. Things happen very fast. Sometimes there's bad outcomes. It's a stressful position, but it's also a very rewarding position. How have you managed that rotation issue in your hospital? Over.
Thank you. It's really challenging for losing nurses, especially those who are general nurses, in maintaining them to work in the NICU. What I always do is that I try to find out what's happened and you want to leave the NICU. Though NICU is challenging and is stressful, we try to motivate them in a smaller way to keep them in the NICU to work. And then also motivate them, drive their mind towards specializing in the neonatal care so that they will be able to remain in the NICU. I use myself as an example that though it is difficult, when NICU started, we were only 3 nurses that started the NICU. It was not easy for you to come to work. You will not close, you have family, you come in the morning only to close in the evening. So you have to sacrifice for others to also benefit from your sacrificing. Because if I were not to sacrifice when we started the NICU from day 1, from 2009, I don't think we would have gotten to where we are now. Though we have gotten there, but it wouldn't have been successful like the way it is. People have to start something, and then others will also enjoy from where it is. So normally I try to encourage them and then try my own way to motivate them. So I go out to solicit for funds, and then my own way to see how best we'll be able to motivate the staff to stay in the NICU and then work.
Thank you. Thank you. We have another question, I think that relates to the COVID pandemic and how disruptive that has been to all services. Maybe this is a question for Isabella or Hassan. How have you coped with COVID and trying to keep services going? In this case, the neonatal service. How's COVID affected you, and how have you kept progress moving forward, or maybe you haven't?
Yeah. So can I maybe I can say something first, and maybe Dr. Isabella Sego-Moses, if she has at the national perspective. Yeah. So I mean, just to add to even the issue of the staff attrition, it's been quite a difficult, issue. We try to, at a higher level to work with the hospital management to reduce, because it used to even be worse than that. Maybe within every 3-4 months, you would hear somebody saying that they have been reposted to another unit. But we have tried to work with the hospital management to make sure that at least for the general nurses, if they were going to rotate, it shouldn't be like every 6 months. But what we have noticed, as Victoria said, is that because of the stress involved, the general nurses in particular, want to move after they have worked there for a while. And also there has been a general trend of even nurses just moving out of the hospital, not just moving from the neonatal unit into the other unit, but they move out completely, or some have to go to school. For those that go to school, we don't really have a problem because for many of them, we try to push them to do either pediatric nursing or neonatal nursing so that they can still come back and work with us. I know in the longer term, the solution will lie in getting more specialized nurses. But I mean, in the interim, is working with the hospital management to make sure that the movement and reshuffling is done less frequently. Regarding the disruptions caused by COVID-19, so I mean, we documented a number of the disruptions from the work that we did during the period. One of them was even just a letter to the editor that we had anticipated that there may not be a direct, effect on, the newborn care, but because of the disruptions in other care services. So for instance, maternity care was really affected more directly in our hospital, in that at some point they have to suspend, they actually suspended routine antenatal care. And for those that came, they were just doing emergency care for pregnant women. And this was one of the reasons why we documented in our study published in the Frontiers in Pediatrics that the increased number of asphyxiated neonates that we were seeing is due to the suspension in antenatal care services, which means that, and also, the stay away unless it's necessary slogan, which kept a lot of pregnant women at home until maybe the labor is obstructed or they get a complication, then they were now rushed in. So this was a huge problem. And of course, that led to a decline. We had a general decline in admissions in to the neonatal unit for the whole of 2020. And this was mainly because there were less even deliveries in the hospital, and beyond the delivery, there were less services carried out in the hospital because either a staff or a number of staff in a particular group. So the obstetric teams ran in teams, and then one team for instance, 1 or 2 people get COVID-19 infection in one team, they have to suspend that whole team for about 14 days. And that disrupted the flow of activities. The other thing that we documented was even the change in the other services like vaccination. So the 0-day vaccination for BCG, for instance, dropped by more than 50% in one of the studies that we published earlier on. And that was also a concern. And this didn't just end at the 0-day vaccine, but it continued up to the 9th month, where there was also a significant change in the number of children who get measles, 1 vaccine, and all that. So there was, a huge disruption. Thank you.
Thank you. Isabella, anything to add from the national perspective on the impact of COVID on neonatal?
Yes. So, like you said, there were disruptions partly due to the withdrawal of some of the nurses that attend to maternal and child health services to augment the COVID services. And so they were not available to conduct antenatal, postnatal, child welfare services as they should have. Also, initially, there were challenges with the PPEs. And so health workers themselves were reluctant to even offer services. And a general lack of understanding about how to organize services safely. So we quickly came together at the national level in the Family Health Division and came together, put together guidelines on how to offer services safely, and also on communication with the general public. So whilst we were guiding health workers, we were also putting out messages that it was safe to access care and telling them the things we were putting in place to ensure their safety. And when we look at our data from the beginning of the pandemic here in Ghana through the period, we see a very interesting trend where once we had introduced these guidelines, things started improving and coverage for various services started improving gradually. So, and also once we had more PPEs coming in and health workers getting themselves better protected, we began to see an upward trend again. Thank you.
Thank you. We do have some questions from there in the room. I'll turn it over to the room to field those questions.
Yes, thank you so much. I'm Goldie Nacia, Senior Advisor for Newborn Health for Save the Children and MCGL Ghana. And first of all, congratulate all the presenters. This was absolutely fantastic. And I have a couple of questions for Dr. Al-Hassan. Thank you for, and I'm sorry I didn't meet you when I was in North Ghana recently. So the first thing is that really your reduction in mortality is not modest. 20% is very impressive, and I was yelled at once in my MPH for writing in a test that 20% reduction in mortality is modest. So that's really good. So congratulations on that. My first question is, first of all, how you were able to get to have central oxygen and to be, if you have blenders to provide safe oxygen. I see that you have also cylinders. This is one of the biggest gaps in Africa, is the availability of oxygen and blenders. And the second question is on KMC. As I can see, you have a very nice program in your hospital. And I was wondering if you have the capacity to be training district hospitals to provide KMC as well as a follow-up for these babies after they go to the clinic. Thank you.
Thank you so much. With regard to the oxygen, I think, I mean, my biggest frustrations in the earlier years with working with in the NICU was about oxygen, because mostly we were using either oxygen concentrator or using oxygen cylinders. And apart from the dangers involved with the cylinders falling on the staff and all that, the other issue was the hospital never, I mean, was able to catch up with our needs. So there's always a time that you needed 4 cylinders, but then 2 will be brought because that is all what the hospital has. And then it's a Fridays, and then by Sunday evening, they will call from the unit that we don't have, I mean, the oxygen has run out. And I can't remember the number of times that I have to drive like 1 a.m., 2 a.m. to the hospital just to make sure that we get something to, I mean, keep the babies going until morning. So when the hospital expansion project came up to the second phase, which involved the building of the obstetric block, it came with, I mean, a central oxygen piping, and that was also made available in the neonatal intensive care unit. So with that one, that has solved partly my problem with oxygen, because now I don't have to, apart from when power goes off and then the whole building goes off and the oxygen plant is also off. So we have a few backups for those purposes, but I can't, it's been a long time that I have to go to the hospital in the night because, I mean, oxygen has run out. So that has been a huge relief for me and the team. What is not fully solved is the issue of the blenders, because we have, I mean, apart from the central oxygen, there is also piping for air. It's just that we don't have the blenders to be able to connect these two. And that is one of the things that we have been working on with the increase in the number of very small babies. We are very mindful of retinopathy of prematurity and also chronic lung disease because of giving too much uncontrolled oxygen. So we are working on it, and I think we have a few leeways on that one, on how to get the blender so that it can support the care. For the kangaroo care, as we can see, we have, for the capacity to train other teams, yes, we do have, because as I said earlier on, we now have 4, because the 5th one actually joined the university, but she's still available to support with training for the, the neonatal nurse specialists are there. And the pediatricians are there now. We have about 8 pediatricians in the hospital who have all been trained on, training for essential care for the small baby and even for the big baby, which includes kangaroo mother care training as well. So we do have the capacity. What we are limited with is the space for instance, people to come and have experiential learning by, working in our KMC unit, because it's only 7 beds. So when you have even 3 staff sent from the district to come and observe and then work with us for 2 weeks, it already increases the crowding in the unit. And that is why one of our medium-term plans is to have a bigger kangaroo care center that will not just provide inpatient care, but provide a follow-up care as well.
Thank you.
Thank you, Alexander. Go ahead, please.
I just wanted to highlight the importance of the question regarding safe use of oxygen as we think about going forward, making sure that countries have CPAP according to the small and sick newborn ENAP target. It's not just CPAP, it's safe use of oxygen with blenders. So thank you so much for that question and for highlighting the importance of that. I know there's a couple other questions from the virtual room.
Go ahead, Leah. I understand you have some questions.
Indira had raised.
Oh, Indira and Sue had questions. Do you see them in the chat? The question from, can we flip back? So the question is from the virtual room is, what is the patient, the patient and nurse ratio, and does this change at night? So this might be towards Victoria.
Victoria, can you hear?
Can you hear?
Yes, I can hear you.
Okay. Patient to nurse ratio, and how does it change? During the day, in the night, do you have less?
No, it's still the same. It doesn't change. We are overburdened. You can have a nurse taking care of about 20 patients in a shift. One nurse for 20 patients in a shift.
Yeah. So, but that is generally, for instance, during the daytime, you have more staff to patients. During the night, yeah.
Now it's the same.
Okay.
It doesn't. The list is 1 nurse to 8 patients.
8.
1 nurse to 8 patients.
Yeah,
And
that's
to build on that,
the list is 1 nurse to 8, but the most is 1 nurse to 20 patients.
And the other question. Tom, you can take over asking the questions. Just to build on that question, there was a question from the from Sue as well regarding orientation. Question: do nurses receive an orientation, including a didactic approach and competencies with bedside mentoring before they start working in the unit? And how long, if so, how long is that program? That's for Victoria. Do you mind addressing that, please?
Please, I didn't get you. Please, can you come
So,
again?
do you have any program in place for the new nurses that they post to you before they start working? How long do you take them through orientation and mentoring?
2 weeks. We take them through 2 weeks. 2 weeks orientation training on how to care for babies, and then how to use equipment in the NICU before you start work.
And Tom, I think there's another question from our room.
Hello, everyone. My name is Teresa Shaver, and I'm Senior Maternal Newborn Health Advisor for USAID. And I just want to thank all the presenters for an excellent presentation. The question on nutrition, I'm going to come back to that again if I can. And this is for all the panelists. You have a champion such as Victoria in your hospital, and her one-on-one to encourage nurses to stay. But what are some of your other thoughts of how you can address attrition, especially with specialized neonatal nurses?
Okay, so that is a difficult one. So the first thing is with what we do as a unit. I mean, that is part of the the motivation that we try to give to the staff by talking to them on a regular basis. Then if staff who work in the neonatal unit wanted to, and mainly they are general nurses, if they wanted to go to school, we work on facilitating that so that they can get trained, quickly enough for them to come back and support the work. The other thing is for general hospital-wide address, it's more of a challenging problem because we have worked a number of times to see how we can address that, holistically. But because, the workload and the burden, depending on where you are working in the hospital, is so different. So for instance, if somebody was working in outpatient care services and another one is working in the NICU, the difference is too much as to the workload that they carry. So people generally see that one as, well, then I might also be better off if I went to the outpatient care instead of working in the neonatal unit. So what we are working on doing, which we think may be better for in the interim, is to get the hospital, for instance, to post more so that we reduce the number, the ratio, the nurse to patient to nurse ratio. Say that at least instead of taking care of 8 to 20 patients at a time, you may be able to take care of 4 or 5. And now we do put patients on a mechanical ventilator that even require that you have one nurse taking care of one patient. Those are the modalities that we currently are working with the hospital management to make sure that we get more staff being posted. Then that can reduce the burden on each one of them. It may make it more of a pleasant experience working in the NICU than what we currently experience. In the longer term, I think more training would help to solve at least part of the problem. Because those who agree to go into either pediatric or neonatal nursing have already committed in some way to providing care for these small babies. And therefore, it's easier for us to work with them and mentor them to stay for a longer period.
Thank you.
These are great questions and answers, and we could go on for quite some time. We have quite a few. But a lot of the questions keep coming back to the workforce, not surprisingly, in our experience. This is really one of the biggest challenges. The buildings and the equipment and so forth, those are kind of the easy part. It's like the previous questioner, how do you keep these very qualified people on your workforce? But we do have some questions about how do you structure the training of neonatal nurses? Is it a formal degree program? How much is clinical and how much is didactic? Can you give us a rough outline of that, please?
Victoria, do you want to talk about that because you just graduated?
Is the training done? You have to have your degree before.
Yeah, if it is that membership, like what I have done, you have to have a degree first before you can do the membership for 3 years in the Ghana College of Nurses and Midwives. But we have another one that is for 1 year, that's the associate. That one, you just have to have a diploma before you can do that one for 1 year. The neonatal nurse or pediatric nurse. for 1 year.
And how much of that is clinical training versus didactic, that 1 year?
Rotation, how much is it?
In terms of money or?
No.
So, I mean, in terms of like, how long do you work in the hospital and then how long do you stay in the classroom?
12 hours contact. When we have 70, 30 for theoretical and then 70 for practical.
70%.
70% of the time is practical, and then 30% of the time is for theory.
70% is practical.
Yes.
So your instructors are largely clinical nurses actively practicing.
Yes.
And then
So they are generally, Thomas, sorry. So they are generally posted to the hospitals that have neonatal intensive care units. So, I mean, I have served as a preceptor and then an adjunct lecturer for the teams over the years. And what they do is, so when they are posted to a neonatal unit, we actually, aside from working, I mean, seeing babies in the NICU and then our specialist care clinics, we also give them some tutorials while they are, I mean, on site in the hospital. And they also get to rotate through the obstetric, I mean, theaters and then the labor rooms during the time that they are in the hospital. So they spend a lot of time, I mean, in the hospital setting.
Okay, well, I think we've gone over time, but I wanted to give Leah one last opportunity to comment, just kind of what she sees on the global picture. And you know, USAID has been a leader in maternal child health for decades, and is to be commended for that. And it's wonderful that now this attention is being given to neonatal care. Do you get the sense that now the timing is right for this, given, you know, many competing demands, but we're lagging so far behind in achievement of the SDGs? You showed just 3 countries out of low-income countries are on target to meet the SDGs. You quoted a figure that 80% of these sick and low birth weight newborns are not able to access this care. So the treatment inequity is staggering. And of course, children are our future. So we have a lot at stake here for many, many reasons. What's your sense looking at the global landscape? Are others making this a priority, do you think?
Thank you, Tom, for that very important question. And from my perspective, I think this is our moment for small and sick newborn care. We have the targets, we have the documents, we have the passion, and we have a target that's specific for small and sick newborn care. Coming down the pike, we also have WHO, UNICEF, and USAID working on an operational guide that will inform not only how to provide quality care for small and sick newborns, from merging the content of care with the 10 core domains that have been developed with WHO and UNICEF for operationalizing small and sick newborn care. I think we're building on all the work that has happened with Helping Babies Breathe, essential newborn care, and we're really pushing forward, and we're pushing that needle, and 2030 is right on our heels. So we need to keep our passion and just keep moving and having these discussions and really thinking hard and making sure that we're moving in the right direction, causing no harm, and keeping the baby and the family at the center of every single thing we do.
Thank you, Leah. And I guess it's time to close now. We're over time, but I really want to thank all of our speakers, those in Tamale, and of course, Hassan for coming all this way to the US, and Leah for her perspective as a senior advisor in neonatal care at AID. And thanks to those who joined either virtually or in presence. And we plan to do more of these. I think this has been a very rich experience. Ghana is a tremendous example of a country taking steps, taking action, can be a excellent model for others to emulate. And we're really honored to have had your presence and for you to share your experiences with us. So wish you all safe travels and have a wonderful day.
Thank you.
Thank you.